Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing medication errors and reduction plans. Our objectives today will be to reintroduce medication errors and prevention, to identify opportunities to reduce medication errors, and to understand patient safety. A lot of the material that we're going to talk today is very basic. However, in terms of the objectives may apply to case-based scenarios that you may see and that we'll practice actually in class. So to start out, over about 2,000 years ago, Hippocrates said, first, do no harm. And we have long discussed medication errors and other errors in hospital systems and ambulatory care outpatient systems. But until recently, medication errors were considered to be inevitable byproduct of medicine and an unfortunate outcome of, quote, bad providers. However, anybody who is a provider can make a medication error. And as a result of basically this concept of first do no harm, this essentially led to change much later. In late 1999, the IOM, or Institute of Medicine, published To Err is Human, very famous publication. This report estimated that about 44,000 to 98,000 Americans die each year from medical mistakes, and this generated lots of different media and public attention, as you sure probably are aware of, especially now in today's landscape. And it set the stage for unprecedented efforts to improve patient safety. The IOM death estimate, which was drawn from thousands of chart reviews in different states in the late 80s and 90s, was followed by studies that showed a huge number of medication errors, communication problems in the ICUs or intensive care units. And usually in these intensive care units, these are the sickest of the sick patients. These are actually the patients that I take care of as a critical care pharmacist. And what can happen, because everything is very fast-paced in this setting, most of the time at least, you might have potential for communication issues that may occur when things happen very quickly. You might have gaps in the discharge process that occur. Was a patient supposed to be prescribed a certain med before they got discharged, yes or no? And whenever physicians or other healthcare providers do their medication reconciliation, or basically deciding what medications the patient should be on whenever they get discharged, a lot of times they might get discharged on the same medications that cause them to actually come in with a potential medication error on the outpatient side, but it turns into a situation where they come in because of a medication error on the outpatient side into the hospital. And there are also studies that showed retained objects like sponges in the operating room. So retained objects within a patient that were not noted by the operating team. And obviously that poses a problem because that can be, future vector of some type of issue that happens with the patient, potentially death, depending on what kind of object it is. It doesn't necessarily have to be a sponge. It could be some kind of cutting utensil. Obviously, anywhere someone looks, there's always going to be problems in regards to patient safety. And moreover, accompanying this information in public professional literature, there are many dramatic reports in the media. There are reports about errors involving the wrong patient going to a procedure or a wrong limb potentially being operated on, chemotherapy overdoses, botched transplants, patients released from the emergency department only to die later from a complication like a myocardial infarction, aortic dissection, which is basically a rupturing of your aorta, and more things. I've also heard stories about incorrect organs being taken out For example, a patient was supposed to have another organ taken out, and instead had one of their healthy kidneys taken out. And while that's unfortunate, these things do happen because, again, to err is human. Because we are human, we are always with the probability of fault. And as you realize that we're always at the probability of fault, that's basically why we implement a lot of the safety processes that we do implement. So this table here, table 1.1 that you see here, has a few selected medical errors that garnered extensive media attention in the United States. So what I want you to do is I want you to just be aware of the situation that happened. You obviously don't have to be aware of the names of the people or the ages, but I want you to be aware of, just the errors that occur and the impact that they had. And that you don't even need to know necessarily institution or the year. But there was a daughter of a prominent reporter that died of a medical mistake partly due to lax resident supervision. So lax just meaning not optimal resident supervision, medical resident supervision. And then that basically generated a discussion on how should residents be trained, how they should be supervised, what work hours they should have, and led to laws that eventually led to more regulation on supervision and work hours, and that then culminated in the ACGME, which is a big accrediting organization that basically oversees residency programs to basically decide, how many hours that a resident should work. And technically, residents should work no more than 80 hours in a contiguous week. If you work more than 80 hours, that is seen to be dangerous. And heck, even people working in the 60 to 80 hour range may also see deleterious effects as well. However, 80 hours is basically a hard cutoff on an average of a 7-day period. And as a result, people or residents are mandated to have certain amounts of time off. For example, in a 28-day period, a resident should at least have 1 day off every 7 days on average. There was a famous healthcare reporter who died of a chemotherapy overdose, and that really kind of focused attention on medication errors, ambiguity in prescriptions, and possible role of computerized prescribing and decision support, so CPOE. So as you know, basically kind of our alert system. So if you basically put in a high or low dose, can you be alerted to that before it actually gets verified? And even after it gets verified, it might even flag you. So that, is obviously a concern. A patient died, didn't die, but had the wrong leg amputated. And that focused on basically procedures that developed a surgical checklist, a pre-op surgical checklist, to make sure that operating teams were basically doing what they were supposed to be doing in the operating room. We had a patient who died of dehydration, and dehydration deaths are very prevalent out there. But that led to more leadership within the Johns Hopkins system of institutional and patient collaboration. So, obviously listening to our patients, listening to our patients' family members or caregivers or, patient advocates, basically to say, if something is wrong, like it should be addressed. Patients who received the wrong blood type if they needed blood transfusions. And that obviously led to more regulations on blood typing, more strict communication regarding crucial data with that. And another big one was whenever the newborns of Dennis Quaid were nearly killed from a large heparin overdose. They received a larger than what they were supposed to get heparin dose based on the status that they were basically, in that case, neonates. And that basically kind of renewed a lot of focus, a lot in the media about medication errors and the potential of barcoding, BCMA specifically, barcode medication administration, to prevent prescribing errors. Because if that would have happened, those newborns would have not necessarily gotten the same dose or concentration of the drug that they received. So the most common way that we have of measuring errors in safety is through incident reports. And we talked about this previously in one of our previous classes. And these reports were traditionally completed with pencil and paper, but now most of them are computerized systems. And the most common ones that you hear about are IRIS or MIDWIFE. And these incident reports might be a reliable way of tracking errors, but these are not the only way that we can track medication errors. There are several problems with using these reports to measure the frequency of errors. For example, first, although nurses tend to report errors through incident reporting systems, few doctors do. And remember that our nurses are not the only people who are involved in safety. It's everyone: doctors, nurses, pharmacy technicians, and pharmacists, as well as other healthcare professions. Hint, star on that one. Everyone is involved in the process. And anyone can report through these incident reporting systems. And the reason why few doctors do is sometimes they just don't have time. They might be taking care of patients that are very plentiful at their hospital system, and they might be taking care of patients at multiple hospital systems. I work with many physicians that take care of patients at multiple different hospitals, sometimes far distance away from each other. And obviously that minimizes the time that these healthcare practitioners have to actually report errors. So in some cases, they might just do simple things like telling the chief resident about the error and expect the chief resident to report, but the chief resident might have their own patient load to take care of as well. These reporting systems are voluntary, so that's another problem. The frequency of reports may be influenced by many factors other than just the number of errors. So let's say that an institution has improved its patient safety culture such that the reporting of errors is now strongly encouraged by local leaders, and incident reports result in tangible action. Under these circumstances, an increase in incident reports may well reflect the same number or even fewer errors being reported more carefully. And this might come from a culture also that, even though you're fixing the errors that are out there, people might be scared to report it because it may make them look bad. It might be a case where if you report an error, that you might have action taken against you. And that's usually not the case in many cases, but it might potentially happen depending on, the level of competence of the healthcare provider with whom that error happened with, as well as intention. And I feel intention plays a lot of part in errors happening. Another method of measuring safety is through patient safety indicators, PSIs, obtained through large administrative data sets. And that's actually how we identify a lot of our errors. The largest or most widely used indicator set is basically the Agency for Healthcare Research and Quality's patient safety indicators, which consists of 25 outcomes or processes related to safety. And these are just patient safety indicators. They are not necessarily that a medication error or an error actually occurred. These are kind of like flags per se. And although AHRQ cautions that these indicators should only be used as clues for problems, these sources are really administrative data rather than clinical data. They produce results that may be inaccurate or do not correlate very well with actual safety. And some commercial vendors do just that, and the media disseminates these findings widely, because anytime that you flag certain data as a potential for error, people can take advantage of that. Are there other ways? So when you are looking at incident reports and administrative data, can you actually look at other ways to identify errors? Well, one can review charts, for example, to look for errors. And that can basically be electronic medical charting or handwritten chart information. And this is what Harvard Medical Practice Study investigators did as they searched for, quote, preventable adverse effects. However, one important thing to remember here, hint, hint, star, star, is that chart review is expensive and labor intensive. And this burden may be eased somewhat by EMRs or EHRs, electronic medical records or electronic health records, if they capture data in organized ways rather than just free text. Poor charting can be an issue as it basically increases your propensity to commit errors. And whenever you're looking at charts, you may not necessarily know what you're actually looking for. You might not know whether or not an error actually happened, unless you maybe have a lot of clinical experience, and that takes time to develop. Even with myself, I didn't know necessarily how to look at a chart whenever I first looked at a chart. But after you gain experience in basically working at patients with a chart system or electronic healthcare record system or health record system, you won't necessarily know how to basically identify an error occurred. And sometimes, remember, an error might be an error of commission or an error of omission, where nothing was done in response to an error or a problem. One way that we do try to flag these medication errors or potential for errors is the use of trigger tools. And these are a favored method to measure incidents of adverse events in many healthcare settings. Whenever my students come on API rotations with me for general medicine, they actually will look at reports of different trigger tools. So the use of triggers or clues can help identify adverse drug events in an effective way for measuring the overall level of harm from medications in a healthcare organization. Remember that these tools that we have are not always going to be the end-all be-all saying that there is a medication error, but they can help provide us ways to investigate a little bit further to see if a medication error actually happened. And the most popular of these is the global trigger tool. So the premise behind trigger tools is that some errors in care will obtain a response that can be tracked, in essence a clue that an adverse event or potentially an error may have occurred. So y'all are most likely familiar with a lot of these different trigger tools. You just might not necessarily know about it because you probably haven't necessarily heard of the term trigger tool or seen how it's used. But for example, say if you have a patient who has overdosed on warfarin, they may be given a dose of vitamin K or fresh frozen plasma, FFP. And FFP contains clotting factors to counteract the excessive warfarin dose. The fact that they got vitamin K on their profile or their medication profile may be an indicator that basically an error has occurred. So whenever you see a medication profile that has vitamin K on it, you might immediately think, hey, oh, they might have basically been on warfarin and maybe had an elevated INR level. That could very well happen, but you can also have a converse situation happen where your patient has cirrhosis, for example, a pre-existing condition, and doesn't make a lot of clotting factors. Sometimes in patients with cirrhosis, some physicians might give vitamin K to try to lower an INR level, just basically due to just the cirrhosis. That's not an error. And obviously, whenever you're searching vitamin K for vitamin K orders in a report, that might pop up as a situation that you basically use as an investigation whenever you do a little bit of further chart review. However, the warfarin overdose might be a potential medication error that might occur. So really, these trigger tools are used as kind of flags to say there may be an error here, but it doesn't necessarily mean that an error exists. Another example is a patient who received too much morphine may be treated with naloxone, and we hear much more about naloxone in the news, basically now being available outpatient for patients who have potential for opioid overdose. A patient may have been insufficiently observed on the medical ward, and they may need to be transferred urgently to the ICU. Maybe, they had some type of vital sign, like maybe a low blood pressure that was not necessarily flagged. Say they had a blood pressure of 80 over 40. That's obviously a problem, right? That could basically mean that they are septic. That could basically mean that they are severely dehydrated. That might mean they have a heart failure exacerbation or cardiogenic shock, basically where their cardiac output is low and generating a low blood pressure. One trigger tool that could be used in that case is if a low value comes up on continuous blood pressure monitoring, then in that case, it can alert the nurse or whoever is taking care of that patient to basically address it and basically go clinically evaluate the patient. Remember that just because you have a low blood pressure value doesn't mean that it's necessarily real. You might have a blood pressure cuff misplaced. You might have, a situation where that cuff is not on properly, where it's measuring potentially a blood pressure not accurately, say if it's on your arm, for example, on the lower forearm versus being on the upper arm. That might trigger a reason for an error to happen. And remember, if that cuff doesn't have sufficient basically tightening around the cuff, or basically if you don't put that cuff on properly, that can obviously result in a bad blood pressure reading. So that's something you always have to investigate whenever you see these out of range values. You have to really assess it clinically. Although trigger tools obviously are not perfect, sensitive or specificity-wise, they provide good interrelator reliability and often identify cases of medication errors that incident reporting or administrative data systems miss. Hint, hint, star, star on that statement. Because triggers do not represent errors or even true harm. They are best used as a screen, again, just as a screen or a flag, followed by a more detailed chart review. The use of global trigger tool currently involves significant labor cost, largely for the follow-up of chart reviews, because anytime that you have a necessity to do a chart review, that takes up someone's time. And say if a pharmacist takes 30 minutes to do a chart review, if your pharmacist is getting paid $70, $80 an hour for some more experienced pharmacist out there, they actually may account for that in workload, because that's basically a $35 to $40 chart review at that point. And some of this effort may be automated eventually. Some of it currently is automated to an extent. Selected triggers from the global trigger tool are going to be shown essentially in table 1-2. And this table here just provides a trigger of examples of what can basically be flagged. This is a hint, hint, star, star list. So I want you to know or be familiar with this list. So in terms of care module triggers, any code or cardiac arrest, a blood drop in hematocrit, patient falls, readmissions within 30 days, transferred to a higher level of care, so like maybe from the floor to the ICU. Surgical module triggers, return to surgery, intubation or reintubation. So anytime someone is intubated or reintubated, that's obviously a problem that we need to address. Did it happen because of a patient's just deteriorating condition? Could that deteriorating condition be prevented? Post-op troponin levels above 1.5, that might indicate that patient may potentially have a lot of cardiac muscle damage. Medication triggers, these are very important for us, hint, hint, star, star. PTT greater than 100 seconds, that might indicate that, hey, the patient's heparin infusion dose is too high. INR greater than 6, that might indicate that our patient may have a warfarin overdose. But remember that INR may be elevated in cases of cirrhosis, so we have to keep that in mind also. Rising BUN or serum creatinine greater than 2 times the baseline, that may flag AKI. We might need to address that with maybe potentially fluid resuscitation. Vitamin K administration, Narcan, just like we talked about on the previous slide. Abrupt medication stop. So maybe they stopped a medication that may have been clinically indicated for a patient. ICU module triggers, pneumonia onset, readmission to ICU, intubation or reintubation again pops up here. Perinatal module, 3rd or 4th degree laceration, so things like pressure ulcers. Say if there's documentation of a pressure ulcer, that needs to be reviewed and basically determined if it was there previously or if the hospital may have been responsible for that. Say if they didn't turn the patient every couple of hours. Readmission to the emergency department within 48 hours, that's obviously a problem. Did we address what the problem was the first time? Time in the emergency department greater than 6 hours. Did we get that patient addressed? Has that patient been seen? Have they been transferred to an appropriate unit? Maybe they need a higher level of care and they don't have enough ICU beds at the time. So table 1.4 here shows different strategies for measuring patient safety and harm. This is a hint, hint, star, star list, a retrospective chart review. So that's considered basically one of our gold standards, but like we said, we have many disadvantages with that. It's costly, labor intensive. We might not necessarily know what we're looking for with it. We have voluntary incident reporting systems. They're great for reporting different things, but they only capture only a small fraction of events. People might be reluctant to report themselves or report others, and there's no standardization or uniformity of the adverse events reported. You might have automated surveillance, and that might be things like your trigger tools, and these can be used retrospectively or prospectively in screening patients. But you need obviously electronic data to run automated surveillance in a high proportion of trigger cases or false positives, like the case where I talked about with the vitamin K and cirrhosis patients. Administrative or claims data, AHRQ, patient safety indicators. They are low cost, readily available data used for tracking across large populations, but a lot of times this claims data might not have a lot of clinical data associated with it. You might see that, oh, hey, the patient, is on metformin. They probably have prediabetes or diabetes, but that doesn't really tell us that there's an error that is there. However, if you had a case where, a claim was made for glucagon administration, like IM glucagon outpatient, for example, which doesn't really happen very often. But if you have a claim for that, that could be a potential flag of saying, hey, does my patient have a history of hypoglycemia where they're obviously not able to take in anything orally? That's a concern. This slide just shows proportions of patients experiencing adverse events who temporarily suffer disability or who may have permanent disability or death. And you see, all I want you to kind of get from this slide is as the age of a patient goes up, basically the likelihood, say if they do have a medication error, just in general, and I know this doesn't always have a linear correlation. It has a general linear correlation except for this temporary disability here at age 15 to 19. But basically, all I want you to get from this slide is that the older a patient gets, the more sensitive they are to the events of an adverse event, and as a result, that may present in temporary disablement, permanent disablement, greater than 1 year, or even death. Probably the reason why we have a higher incidence between the 0 to 14 age is that we do have a lot of pediatric, neonatal, and infant-related medication errors that actually do occur. So just keep that in the back of your mind here. So here's an example of a situation. 2 elderly men presented to the ED on the same day, approximately at the same time, with injuries to their hips, to their right hip specifically. One man was incoherent, went without family, and the other man was aware and alert. The admission registrar did not register the patients or place identification bands in a timely manner. Does that sound like a problem? Probably. The ED physician and nursing staff relied on their memory instead of following hospital policy regarding the use of 2 patient identifiers. So anytime that we try to identify patients in the hospital or in a healthcare setting, we try to identify them with 2 identifiers, maybe their name and their birth date, maybe a name and some other kind of piece of identifying information like their address. Radiology technicians did not follow hospital policy regarding use of 2 patient identifiers either. And a requisition form for a test or a procedure was incomplete. Staff did not question diagnostic discrepancy between Mr. Jenkins, the patient's first and second x-ray. And the orthopedic surgeons did not confirm pre-op physical findings reported by physician's assistants. The operating room staff did not appropriately display Mr. Murphy's x-rays on the operating room prior to the start of a procedure. And as a result, these patients actually got mixed up, and the patients, or basically a patient basically got a wrong surgery. So you see here, basically there are a transcending plethora of steps that have occurred that resulted in a possible error happening, in this case, a wrong patient surgery. Fortunately, incidents like the one described are not usual occurrence, but they do happen, and they shouldn't happen, but they do. And that's because obviously we have some interplay of human and technology playing a role here. And it might not just be human error that we saw in the case there, but you might have a technological error as well, because remember, technology is only good as the humans that program it. As of March 2010, wrong site, wrong patient surgery continues to be the most prevalent sentinel event reported to the Joint Commission. And that's about 13% of sentinel events. Sentinel events basically mean events that basically resulted in death or permanent harm. So hint, star, wrong site, wrong patient surgery being the most prevalent sentinel event here. How often do incidents involving patient harm actually occur? In a study done in 2008 showed over 200,000 preventable deaths from 2004 to 2006. That's a lot. And it's estimated that 100,000 patients die of healthcare associated infections back each year, and this study was in 2002. Medication errors are among the most common medical errors, harming at least 1.5 million people per year. And if you think about that, that's about 0.5% of the US population, or basically 1 out of every 200 people. That's very, not great. And although the exact number of patient incidents is not known, what we do know is that these errors have consequences like death, disability, and harm to patients. They might result in additional or prolonged treatment, like we saw in regards to our NCC MERP index, that we have different classifications of medication error, some of which involve harm, some of which don't involve harm, and some of which may result in prolonged hospitalization, may result in some kind of intervention being given, or sometimes resulting in death. And it's important to realize that healthcare can be made safer, and making it safer is imperative. Some reduction strategies that we can do for this are error-proof processes. So trying to make our processes error-proof through use of technology, improving information access, reducing reliance on memory. And if we have to rely on memory, that's obviously not going to be a good thing. Reducing number of handoffs, which is one reason potentially why a lot of nurses actually work 12-hour shifts. If they worked 8-hour shifts, for example, they might have to hand off 2 to 3 times a day, depending on how your shifts actually run, versus if you have a 12-hour shift, you might only have to hand off once or twice. And anytime that you have to hand off a patient, usually a brief history of your patient is given to the next nurse, with any kind of, outstanding tasks that need to be done for your patient, maybe a call to a physician, maybe a certain thing like medication administration that needs to be done at a certain time, things of that nature. And anytime that you have to basically hand off information to someone, information can be skewed from handing it off from person to person. And standardizing tasks. So how do you go about, maybe putting an IV line in for a patient? How do you go about programming a medication pump, which we'll talk about in class? How do you go about doing certain charting tasks? All of these things should be standardized in some way, form, or fashion to where they are done the same way each time. Reducing reliance on memory is important. Work should be designed to minimize the need for human tasks that are particularly fallible, such as short-term memory and vigilance. So if you have someone who, doesn't remember everything, and remember that we're all human, to err is human, we all might not have the potential to remember everything. Checklists, protocols, order sets, or power plans like sepsis protocols or in computerized decision aids are ways that we can basically minimize reliance on memory. Basically, those checklists basically have everything, kind of like we talked about in a previous lecture, that basically would need to be ordered if a potential diagnosis is made. So for sepsis, for example, if we have concern with sepsis, so an infection basically related with related organ failure, we're going to look at different things. We're going to look and want to order a sepsis protocol or power plan order set that has multiple parameters. We want to, have all of our typical temperature, vital signs. We want to take a look at our lactate level for sepsis. We want to look and see if the patient needs fluid resuscitation, if they're hypotensive or they have an elevated lactate. We want to administer antimicrobials ASAP, ideally within 1 hour, to patients. We want to do basically as much as we can and minimize that reliance on memory. So basically a power plan can have all of those steps there with pre-programmed checks, basically, that a provider can check or uncheck. And basically when they order that plan, all they have to go is go down the plan, check what they want and check what they don't want, and then order it, versus having to basically pull up a lot of this stuff from memory. Oh, I need a white blood cell count. Oh, I need a temperature. Oh, I need, a blood pressure. All of that stuff, obviously it could be a list of maybe over 100 things in some cases, but with a protocol, basically you kind of have a multidisciplinary approach to developing a plan of attack if you have a certain diagnosis. And pharmacists can be involved in this process in addition to physicians, nurses, respiratory therapists, dietitians, etc. In a recent study related to clinical information technology and patient outcomes, researchers found that hospitals with automated notes and records, order entry, and clinical decision support had fewer complications, lower mortality rates, and lower cost. Improving information access. Creative ways should be developed to make information more readily available to caregivers. Information must be displayed where it's needed and when it is needed in a form that permits easy access. So, for example, maybe printing resuscitation protocols like ACLS protocols that basically tell you the steps for CPR or medication administration in the event that a patient cardiac arrest. You want to obviously put information where it is needed. So say if someone forgets the ACLS protocol and they, have been trained in it before, but may have forgotten the steps because it's been a little while, then in that case, you might put resuscitation protocols on your crash carts. That's also why ACLS providers are recertified every 2 years on ACLS, because obviously we realize that to err as human, people forget a process after it is learned. Just similar to like whenever we learn material in school, like you are learning right now, you might not necessarily remember this PowerPoint in this moment 2 years ago, or 2 years in the future, I apologize, 2 years in the future. However, through reintroduction of the material later on, you might remember some components of it long term, but you might refresh yourself on individual details if you need to. Mistake-proof processes. Where possible, we should structure processes to where errors cannot be made or have a low likelihood of being made. And this can require the use of forcing functions. So computerized systems can be designed in a way to prevent entry of an order for a lethal drug or a lethal dose of a drug. So say if you put in, for example, with the example of Dennis Quaid's newborns earlier with the heparin dose, if the error occurred from a process of putting the order in to an EHR, then in that case, the EHR could have flagged the situation. However, most likely in the case for Dennis Quaid's newborns, and that probably happened related to a barcode administration error. Now, obviously, a pharmacist can go through and verify whatever they need to, but there are sometimes hard stops that will prevent a pharmacist from verifying just anything. Obviously, a computer system can prevent a crazy dosing error that might be 10 or 100 times outside the normal dosing limit. And if that's the case, the computer might not allow any of that stuff to happen until it is corrected. So that's basically an example of forcing function. It's almost kind of like, say, if you were to take a Google survey, for example, or in Google Forms. Say if I were to administer you a survey and I required basically one answer to be required for you to answer. Basically, that's another type of forcing function. It's basically forcing you to answer my question before you proceed on. And sometimes these forcing functions in EHRs have only a certain bandwidth of answers that they will actually accept. Say, for example, in terms of the dosing or even in terms of route. We know that metoprolol tartrate is typically mostly only available orally or IV. So if you put that it is a rectal medication, that might basically put up a flag because metoprolol tartrate is not routinely given rectally. We need a standardized task. So we want to provide an effective means of reducing errors by standardizing processes wherever possible. And if a task is done the same way every time by everyone, there's less chance for error. Makes pretty much common sense. Hint, star on that statement. Reducing the number of handoffs. Another hint, star here. Many errors come from slips in transfer of materials, information, instructions, or supplies. And a lot of times this may happen with nursing handoffs on shift changes. So a lot of times nurses will come in either at 6 or 7 a.m. in the morning and leave at 6 or 7 p.m. at night if they have a 12-hour shift. And processes with fewer handoffs reduce chances for mistakes. If the steps of an ED admission process and related patient care activities were flowcharted, it would likely reveal unnecessarily complex steps and transfers of information. They might have transferred too much information. They might have transferred not enough. It's important to eliminate these handoffs as much as possible. Obviously, it's not realistic for someone to work 24 hours straight, but we try to just minimize these handoffs as much as possible. It wouldn't probably be realistic for a nurse, for example, to have a part-time shift in most cases. So like say if they were work a 4-hour shift, that would require nurses to come in basically every 4 hours to basically change shift. That's not really realistic. We want to try to minimize that as much as possible for basically what can be considered a standard work day. And nurses may work potentially a 12-hour shift, but in that case, they might only have to work 3 or 4 times a week on average, which might also provide a little bit of convenience for them. Reducing reliance on memory. So we want to revert to alternative methods that basically reduce our reliance on memory. So, obviously identification bands are a very good way to reduce reliance on memory. We don't have to necessarily always remember the patient name, even though that's really probably good for patient satisfaction scores. We want to apply strictly applied protocols for patient treatment and diagnostic testing, which allow incorporation of checking 2 patient identifiers and not allow for any informal variations of this requirement. We want to improve information access. So, for example, patient identity, clinical information, practitioner performance data. We want to look at healthcare information technologies, and we want to see that they are designed to permit access to clinical information by all appropriate practitioners. And that may have actually, helped the radiologist identify the error in that case that we talked about earlier, where if information was communicated appropriately from person to person, errors may not potentially happen. Appropriate methods for collecting and trending practitioner performance data that can foster an improvement of safety culture are also needed to change punitive culture, generally associated with peer review process. So in the hospital, there might be a peer review process where your peers of basically the same healthcare profession basically look at your performance in some cases. A lot of times this occurs whenever something bad might happen. So say if a doctor appeared to, not do something correct for a patient, and a patient maybe passed away or died. Did the patient pass away because the patient was just, that morbidly sick to the point where the attending physician couldn't do anything? Or was it because of the physician and something that the physician did? Maybe if it was sepsis, for example, did the patient not get antibiotics quickly enough within the 1 hour recommended time span to get antibiotics per the surviving sepsis guidelines? If that's the case, what process or person did that trigger down to? Did it trigger down to basically, oh, well, we didn't identify sepsis quick enough? Well, why didn't we identify sepsis quick enough? Oh, well, we didn't have a trigger system that could do that. That might be something like, say, in your root cause analysis project that you might look into. You want to ask why. Why did these processes not happen appropriately? Or why did the patient get harmed? Why? And basically go back to whatever was a root cause. But you also want to look at other causes that may have played a smaller role, may not necessarily been the root cause, but may have potentially played a role here. And that's also kind of what peer review process does. It kind of almost implements a root cause analysis based process to say if something was done correctly or incorrectly. Error-proof processes. So processes that basically minimize or stop error from happening. This can happen with patient identifier information being entered into a system before allowing the radiology technician to proceed with a diagnostic imaging study like a chest x-ray. This process would have been more error-proof. A point-of-care barcoding system that matches identifying information in the system to barcode the patient's ID band to their basically medical record could have reduced a mistake happening in that case that we talked about. So case 1 here, midwife takes wrong drug vial off of the shelf. So a midwife intended to give a pregnant patient with premature labor an infusion of a drug that inhibits labor, but at the moment she was taking the vial from the shelf, she got distracted. And that's why we typically have a timeout process whenever we are collecting our medications from a automated dispensing cabinet like a Pyxis or Omnicell machine. She continued her intended action but chose the wrong vial, and fortunately she discovered her mistake before her last procedural check, before coupling the infusion set to the patient's IV line. Obviously, with barcode administration, that can basically help minimize this type of situation from occurring. But remember, not in all healthcare systems do we have barcode administration. The procedure allowed a drug that inhibits labor to be stored on a shelf close to a drug that stimulates labor that had never resulted in a medication error. When the midwife nurse was distracted, she had a latent error, a faulty drug, basically she picked the wrong drug vial off of the shelf, and that contributed to her error. Basically, because these two drugs were maybe next to each other, that probably wasn't a good thing to have two drugs that are either similar in name or opposite in effect right next to each other. And that basically might dictate how we basically fix processes in the future. We might separate those two things on the shelf, even if they have a similar name, or if they have an opposite effect, or a similar effect in some cases. Like, you might have metoprolol tartrate and metoprolol succinate. You might have those two drugs, but obviously they are very different. You might want to separate them on your shelf so that, people might not necessarily pick the wrong one, so then they're more conscious of which one they pick. A safety barrier is an administrative or technical constraint that can act in one of two ways to prevent accidents. Safety barrier can hinder the individual from committing an act of failure, or it can contain the effect of an act of failure. An example of a technical barrier is the manner in which EKG electrodes are designed to prevent them from being plugged into the main power supply. You obviously don't want to electrocute someone. A computerized system for prescribing drugs, which requires that the dosage, route, and frequency be entered for all medication orders. So remember, drug dose, route, frequency. That's another technical barrier. A procedure that requires double checks of information before action by an individual is taken as an example of an administrative barrier. And safety barriers can be weak or strong, and they might even be absolute or relative, depending on the barrier's ability to contain the effect of or to prevent active failures. So figure 2.1 here just shows the typical medication accident trajectory. We have situational factors that are obviously in our healthcare environment, and that can lead to a latent failure or an active failure. But if you have a safety barrier there, and one that I always commonly think of as barcode administration, if we have a safety barrier there, that can prevent the explosion that we have from a medication error reaching a patient. And what we use in a lot of these cases is a set of problem solving, depending on if it is a skill-based problem, a rule-based problem, or a knowledge-based problem. After studying operators who control technical complex systems, mainly nuclear power, Rasmussen and colleagues in 1986 suggested that human problem solving can be categorized in three different ways: skill-based, rule-based, or knowledge-based. This is often referred to as the SRK model. And this approach has been used in many different human factor studies. Skill-based problem solving is usually highly automated, used in highly automated work processes and involves stereotypical motor movements like working on an assembly line, or driving a car, retrieving medication vials from a storage area. It's basically just the skills that you basically have to do basically some type of task, and a lot of these are task sensitive. So keep that in the back of your mind, hint, hint, star, star. You might have a rule-based problem solving, which might be used in novel situations in which we are able to recognize features from similar situations. So, maybe that might be something along the lines of, maybe doing a checklist. For example, what is the rule? What do we actually have to follow in order to get a task done? Knowledge-based happens in novel situations where a ready solution to a problem cannot be retrieved from working memory. And in some cases, it might not even be necessarily training. But that part can come into a skills-based problem or a knowledge-based problem. In a knowledge-based problem solving, it appears that we try to restructure the problem to give us hints as to which ready-made solutions from our long-term memory could be applied to the situation. So case in point here, an example, 42-year-old woman undergoes a partial thyroidectomy. Shortly after the operation, she shows a developing hematoma in the wound area. The surgeon and the nurses and the patient's nurse monitor the situation, and then the surgeon decides to bring the patient back to the operating room for removal of the hematoma. He notifies the anesthesiologist by phone and has communication with him in a short form in a corridor outside the operating room. The surgeon goes off to then attends to some other matter, leaves the anesthesiologist in charge of the patient, and the patient's doing fairly well and can talk to the anesthesiologist. The anesthesiologist believes that it's best to intubate the patient right away. He starts an IV line, administers muscle relaxant or muscle paralytic, and attempts to intubate the patient. The intubation is not successful. He tries to ventilate the patient with a mask and also fails. He makes a new attempt to intubate the patient and initially believes the tube's in the patient's trachea, but after another minute or so finds that the second intubation was also a failure. The surgeon arrived and a lot of other staff also arrived as well, and some debates going on between the surgeon and the anesthesiologist whether or not the patient is properly intubated. Situation's close to panic. After 6 minutes or more, successful ventilation is finally established, but it's too late and the patient expires. So basically this patient underwent some kind of issue of respiratory distress, and basically the anesthesiologist tried to intubate this person but wasn't able to successfully do that. So is this a skills-based, knowledge-based, or rule-based issue? It depends on, what actually happened. The anesthesiologist in this case was presented with a situation that he presumed was similar to other situations he encountered. He made a rule-based decision to intubate the patient right away based on the things that he actually saw. So basically, they might have a criteria of looking at the patient, visibly inspecting the patient through physical exam, seeing what their respiratory rate is potentially. And that might have led them to decide to intubate the patient, which obviously proved to be a wrong choice in this case. The anesthesiologist performed the intubation the way he was used to doing, using his skills. He then gave the patient the paralytic and then intubated them. He used a rule that he very frequently used to solve this kind of problem, and the rule that he thought was strong, but it was also a wrong rule. So he potentially, intubated them for a wrong reason. Maybe the patient didn't need to be intubated. And he had a poor understanding of the situation, probably from the lack of communication he had with the surgeon, causing him to read the wrong cues. Maybe he read that the patient was having respiratory distress whenever the patient maybe might have just been like that chronically. And, as a result of trying to intubate the person and using a paralytic on them, the patient, obviously developed more respiratory distress and maybe didn't have respiratory distress in the first place. It might have been helpful if the surgeon had better conveyed the situation to the anesthesiologist about the patient's background, about what was going on, and the dynamics of the problem, before, the anesthesiologist made the rule-based decision to intubate the patient. The skill would have been the way that the anesthesiologist intubated the patient, placing the tube, going along the lines of basically putting the tube down the throat, providing sedation, and then a paralytic. That might have been the skill-based. The knowledge-based, might have, played a little off of the skill or the rule and basically say, oh, I need to do this based off of this thing. Was it a lack of knowledge of the anesthesiologist because he didn't have the information from the surgeon? So a lot of these things actually blur, but some of them can be very easily separated. One other example is, say if, someone is not provided the appropriate knowledge or training, say if, they are not, if they haven't gone through all of their schooling yet and then they're expected to do a task, is that a skill-based problem or a knowledge-based problem? It depends on what the individual thing is. If they're asked a simple question, it might be a knowledge-based problem. If it is related to a skill, it might be skill-based. But in this case, lack of communication caused the problem to be cognitively unspecified for the anesthesiologist, and that was the reason why the problem was read wrong. Why do processes fail? Processes fail for a variety of different reasons. It could be human error or basically electronic errors we discussed, and it can be a combination or individualized components such as variable input, complexity, inconsistency, tight coupling, maybe one situation leading to the next, which was maybe not appropriate. Human intervention, tight time constraints. If you don't have enough time to do something, obviously you're going to have a problem. Hierarchical nature, maybe a process of, a physician made me do this, or some other kind of health care provider who was above me made me do something that was incorrect. That could cause a problem. We don't want hierarchical natures to necessarily cause problems, but a lot of times in healthcare systems they exist. So how do you handle those appropriately? A lot of times you just kind of figure out how to work with people in practice. And that's why, we do a lot of team-based learning with y'all, where we have y'all work in teams to basically have you interact with others and see how to work with others. And that's important in the healthcare environment. If you have any questions about today's lecture, please let me know. Thank you and have a great day.